Welcome to Part C, originally one video, now split up into three, covering Chapter 7. So the last slide we left off with was this idea that that blood cells will coagulate. Either they will form these loose platelet plugs that will then activate thrombin, and thrombin is an enzyme that will then convert fibrinogen, which is the precursor, to an active polymer of fibrin, which is the basis of a clot. And we don't want to do that, so we're going to use drugs in order to prevent that. So let's move into the Gladson figure now. What's going on in the platelets is that the platelets contain an enzyme known as cyclooxygenase. And I've mentioned this already in class. This is something we should already have, at least have heard that word. Cyclooxygenase takes a phospholipid, and we know phospholipids from plasma membranes, and phospholipids can be cleaved, and we create this fatty acid called arachidonic acid. I don't want to get too crazy with the terms here. This is basically a metabolite product of the breakdown of a phospholipid from the membrane. This fatty acid precursor can be converted into any number of things. You can convert it into an inflammatory signal through what's called a leukotriene, and this leads to some sympathetic activation, vasoconstriction, bronchoconstriction, and edema. So this is one way that this goes through one type of enzyme. The cyclooxygenase enzymes, on the other hand, create other molecules, and one of those molecules is that thromboxane A2. So this is pro-inflammation here, so a cyclooxygenase can create the prostacyclin, but it can also create this thromboxane, which really is involved in that platelet aggregation. That's what we're getting after here. We're going to go after this guy so that we get after the platelets. But the big deal is that if somebody goes on antiplatelet therapy, anti-atherosclerotic therapy, or blood thinner therapy, education is critical. So having a plan of education, if you have somebody, having a plan to make sure they've got their routine down and that they have the right diet associated with this therapy. It's very, very important. Education is critical. Why? Because if they start eating a lot of green vegetables and they get a little bit neurotic about their diet, they may actually be counteracting their medication. So warfarin for issues of drug-drug interactions. We need to make sure that it's dosed right so that they have the right clotting, so that you don't have them bleed out accidentally. When I mean bleed out, I mean just bleed in general. So if you have too much anti-clotting, they will begin to start bleeding spontaneously under their skin. They need to make sure they have a good routine and they have an emergency plan if something isn't working out right. Like in that previous slide, the therapeutic concerns are bleeding or loss of patency of the vessels for any reason. Like procedures like debridement, that is that when they'll go in and try to remove damaged or infected tissue in order to allow healing to occur. Under normal healing processes, you have to remove the dead and dying material before you can lay down new stuff. And so what debridement is doing is trying to accelerate that process on a macro level or an external level to allow for healthy tissue to heal. Rigorous activity that involves impact or repetitive stress, that sort of a thing could be a therapeutic concern with somebody who's on a blood thinner. There may be some benefit to rigorous activity, but it should be certainly low impact. And thirdly, we need to watch out to make sure that their dosing is correct. If their dosing is not correct, they will see symptoms of spontaneous bleeding. That could be nosebleeds or bruising that may not be associated with trauma. Because what's happening is the blood vessels are spontaneously bleeding under the skin. So it looks just like a bruise, but it didn't happen because of blunt trauma. Now that can be difficult in a patient that has lowered mental status or spasticity. They may accidentally bump and not realize it. These things will happen spontaneously. They may have some ischemic pain, or you'll see blood or urine in urine, blood in the urine or stool due to spontaneous bleeding that's occurring. And so the key is to get the right dose so that they don't, but you're still getting that anticoagulant benefit. Drugs and pharmaceuticals are a powerful, powerful thing. There's no getting around their utility and the usefulness of it. Nevertheless, they don't work in a vacuum, especially in chronic disorders like this. And so education and lifestyle changes are going to be critical to the patients that are on these therapies. This is a pharmacology class, but it doesn't mean we can't use bridging concepts to get you to where you're thinking about these things in addition to the pharmacy that they're seeing. You see these drugs on their list, you look at what they're doing, and you can offer some additional suggestions in order to increase the likelihood that these drugs will actually work. Though the first thing is, let's get rid of the aggravating factors. Things that are going to be pro-inflammatory, things that are going to be pro-stress and pro-clotting. And good luck. It's not easy. It's the easiest concept in the world to say, hey, you got to quit smoking, but it's so addictive and it's so ensconced in people's habits and lifestyles and identities in some cases that it really does take it takes a village. Okay. It takes a village to get somebody to stop smoking, because people don't think of their own best interests. They'll think of other people's best interests, but it's a lot harder to think of their own. So good luck with that. It's an ongoing battle. And if you can get someone to stop smoking, you've probably saved their life. Exercise. And it doesn't have to be super rigorous exercise. Anything that will get in sort of the 40% heart rate range. And again, you might have to work with it if they have issues with heart, but anything that'll get that heart rate going a little bit more. Certainly it's going to improve the fitness of the heart, but the flow of blood in these blood vessels is actually an anticoagulant. That's one of the most amazing things that I've learned about cardiovascular physiology, is that blood flow actually is anticoagulant, and it is also anti-thrombotic and anti-sclerotic. It will lift away cholesterol. It will increase nitric oxide, increase vessel reactivity. So even the most modest of improvement in exercise regimen will go a long, long way to really helping these patients. Certainly eating healthy foods, and you want to eat across the rainbow here. You don't want too many greens. Too much vitamin K can actually counteract the anti-clotting. So they want to make sure that they're eating, and the phrase I say is eat the rainbow, eat different colors, blueberries and cantaloupe and carrots and radishes and grapefruit and oranges. Mix it up. A varied diet has so many benefits above and beyond this, but certainly we don't want to eat too many. Again, vitamin K is kind of the big one. Manage their stress. Let's work on what's driving up their blood pressure, if there is something along those lines. Exercise will do that as well. Certainly, smoking will do that. Just live a more relaxed lifestyle can help if, for instance, they can't exercise. Manage high cholesterol. So we might talk about other drugs. We'll be talking about those later. Try to control that blood pressure, diabetes, or other chronic disorders that are either inducing stress or contributing to an atherosclerotic progression. So far, we've been paying attention primarily to the coronary artery type diseases. Because those are more devastating and thus more common, because some of these things may go undiagnosed. If they become diagnosed, it's usually in later stage disease and so forth, but it doesn't mean it's not significant. And so I want to talk a little bit about arterial occlusive disease, or also known as peripheral arterial disease. It's the same story. So if you have a blood vessel somewhere, it can be occluded. If you have a lymphatic somewhere, it can be occluded. And so having an awareness of the commonality across PAD versus coronary artery disease is a good idea. So you're going to start with this narrowing, and that can be because of hardening or buildup of plaque, just like in the coronary artery disease, atherosclerosis. You may induce occlusion due to thrombosis or embolus. It may involve lining or damage. It certainly involves endothelial dysfunction. Where you're going to most likely see it outside of the heart is going to be in lower extremities, and there's a very, very specific reason for that. That's because when blood gets out to those lower extremities, it tends to have lower pressure, gravitropic effects, and tends to be more static. That is to say, it's not moving. You will see it in places where there are blood vessel splits. They call that a bifurcation. The reason that's a common place for plaque to build up, and by the way, cardiologists and vascular physicians almost know down to, they almost have a hit list of where they know plaques will build up, particularly in critical vessels like the carotid artery or major arteries in the brain, because those are where there are bifurcations. And we have bifurcations, you have turbulence. You have blood that's kind of spinning around in a given spot. And when it's kind of spinning around or kind of moving slow, it is prone to clotting. Even healthy blood is prone to clotting. What we see is that we see PAD as a part of the overall profile of the patient. So if somebody has atherosclerosis, if they've already got signs and are dealing with their atherosclerosis in their chest, you as somebody working with these patients on routine and so forth can help build awareness. Because these can either circle back and contribute to coronary artery disease, or you'll get secondary sequelae in terms of you'll throw one of these clots and then it'll end up in their brain or in their carotid and so forth, and that can be devastating. So while we do focus on the heart because it's the most common, these peripheral artery diseases go right alongside. So if somebody has CAD, is already dealing with a clotting issue, they are at risk of other types of disorders. And we want to be aware of that. And there is relatively low awareness just because people just don't pay attention to it. It just doesn't seem as serious. And so I want to kind of include that as part of the overall discussion of thrombotic disease. And so now I'm going to go into a little bit of a crusade here. I don't mean to depart too much, but I think this is a very, very important thing. Given that most of my students in this class are at the beginning of their reproductive years in terms of being able to give birth to children, we want to talk about something that is an issue. Over 3 million cases of it a year. So that's the idea of a certain mutation in prothrombin, the prothrombin protein. That's the precursor of thrombin. There's an isoform of it called factor V Leiden. It's a mutation that will lead to hypercoagulability when either during pregnancy or when using estrogen in any form. That can include contraception. So it is something that's serious. I had somebody very, very close to me have a near fatal issue with this. So I want to bring it to your attention because you guys are all important to me. And so if you have the ability to find out what your status is on factor V Leiden, that would be something that's very worthwhile, because you will have increased coagulation issues. You may be at risk of deep vein thrombosis or other types of coagulation disorders. And given that I said I have kind of been ranging a little bit away from the book, I've been abbreviating the book quite a bit, I'm going to kind of bring you back a little bit to some key pages. Pages 97 and 98 are very, very important. So I want you to focus on these and read this section a little bit more. When it comes to the formation of a clot, when it comes to the formation of thrombosis, there is this theory known as Virchows Triad. Virchows Triad is this, and you'll see this in everyday life for things as mundane as flying on an airplane and so forth. That is that thrombosis will form when you have coagulation signals or the onset of vessel wall injury coupled with blood stasis. You remember that I said that vascular physicians can almost have a hit list of where they know clots will form. That's due to the fact of stasis. If you have a bifurcation, if you have turbulence in the blood, as opposed to what we call laminar flow, stasis is a big predisposing factor to clotting. So people who live very, very sedentary lifestyles, people who are sitting a lot, truck drivers, people who are sitting on long distance flights, you ever wonder why they always give you drinks on planes? That is in order to stave off deep vein thrombosis. By hydrating people, because they're actually at high altitude. When you fly, you're not at the same as sea level altitude. You're still pressurized the cabin, but you're at about 8,500 or 10,000 feet, the cabin pressure relative to sea level. In any case, they give you those drinks in order to keep you hydrated, because if you're dehydrated and you're sitting around in those crampy little chairs for more than a few hours, that can lead to spontaneous formation of deep vein thrombosis. Which is why if you're on a flight for more than 2 hours, you ought to be getting up every half an hour, 45 minutes, and moving your legs around. If you have the factor V Leiden gene mutation, you're at a hypercoagulable. If you smoke, and so forth. All three of these, vessel stasis or blood stasis, slow-moving blood that's trapped in the veins, or if it is in a turbulent spot in the arteries, if there's inflammation or injury to the vessel wall for any reason, and there's the issue of hypercoagulability, all can contribute to Virchows Triad and lead to formation of clots. And unfortunately, even though most women will outlive men, women are more susceptible to deep vein thrombosis. We'll abbreviate it DVT. That's because of the factor V Leiden, that's because of the elevated estrogen and so forth. So the way you can stave off is stay well hydrated, exercise a little bit every day, try to just be in an active lifestyle. Hey, eat spicy food, it's good for you. I like spicy food, it's really good. Or other types of varieties of ethnic foods that have ginger, like for instance Asian foods, or turmeric, which is common in curries and Indian food. Apple cider vinegar is known for helping serve as sort of an anticoagulant, but that exercise is critical. Get out there and exercise. And foods rich in vitamin E, broccoli, avocado, olive oil, almond milk, which is delicious. Anything like that. That type of awareness, whether it's in yourself, which I am all in favor for, as well as people that you care about, having this sort of healthy lifestyle to avoid something that's very, very preventable, but that young women are particularly at elevated risk for. And so I've given you the fun part on the previous slide or so, illustrated the risks to you. But here's what you have going on if we do get this. The first thing is a pulmonary embolism, and I have literally seen this in my undergraduate class. I had a young woman in my class 3 or 4 years ago, and she just did not look right. And I said, hey, it's hard to explain. She just looked pale. She just did not feel well. She thought it was just something, but she just had this look, and I had seen it in patients before, and you'll see it. And I said, you need to go see somebody about this. This is not normal. It was lasting longer than just a couple of days. And so she went to the health clinic, and sure enough, she had a pulmonary embolism. She'd had a deep vein thrombosis, and that clot had broken loose from her vein, had cycled around and deposited in her lung. So it does happen, and it happens to young patients that are 21, 22. Okay? And especially women with Leiden factor V are at higher risk. It will lead to things like varicosities in the veins, and that's more of That's more of a cosmetic issue because those are superficial veins. Nevertheless, those veins, when they become insufficient, when they damage those valves and that blood starts sitting down there, it starts to clot. And if a clot breaks loose, then it becomes an embolus. And you can also get scarring in the veins, which can lead to discomfort and pigmentation in a given area, kind of like brown spots or just long-term bruising, if you will. And you can kind of feel. I had a little bit of phlebitis from when I had been donating plasma in my early graduate school years, and you can you can feel it. Okay, so again, the most critical thing is a pulmonary embolism, and your lungs actually serve as a biological filter for that, because what happens is the blood goes to the heart, the blood then from the right atrium it goes, or right ventricle, it goes into the lungs, and then it would come back to the left ventricle and perhaps go into the coronary artery. So the lungs actually serve as a filter. That's why it's one of the most common sites of embolus, because it's returning blood from the veins, and that's the first major filter that the blood encounters, coming back from the veins. So having an awareness of what the warning signs are, shortness of breath, lightheadedness, just a feeling of malaise, it depends on how significant it is. Pain, tenderness, swelling, you'll see edema, in a deep vein thrombosis as well. So good awareness here, not only in our patients, but in ourselves. Management of occlusional and thrombotic types diseases are relatively similar across organ systems, whether it's the heart, the arteries, or the veins. So we're going to use peripheral arterial disease here as our setup here. Assess. What are the risk factors that these patients have? If they're on a drug therapy, does that then key you off that they may have other cardiovascular risk factors that you have to think about from a non-pharmacological perspective? Whether it's their smoking history and their diabetes, how risky of a patient are they for certain types of activities or diets and so forth. And they're going to try to modify those risk factors, control their diabetes, try to get them to stop smoking, make sure that they're aware and understand what's going on with their drug routine. When it comes to meals, types of food, when to take the pills, trying to find ways to facilitate a healthy routine, both in terms of their occupation, but also as well as their therapy. Treatment of hypertension, what we're trying to do is get rid of the stressors. We're also going to be looking at how severe the obstruction or the risk of obstruction might be. Do they have a history of throwing clots? Or do they have significant pain or loss of function in a given area, and so forth. And so there's a lot of things to consider because, again, we're dealing with a system that's involved in supplying nutrients to other systems, so these things can fall like dominoes. You have a vascular issue that then becomes a localized organ issue. Let me give you just a quick example. Say, for instance, they get a clot that falls in their anterior pituitary. They may not only have a clotting issue that may preclude them from other possibilities, that they're going to have endocrine disorders. And that's how complicated some of this stuff can get. The key is to just keep it simple. What are the risk factors? What are the things that are going to drive stress, inflammation, and clotting? How severe is their condition right now, and are there things that we can do to improve that situation? If someone has an issue with unstable angina or frequent angina, the key thing here is to prevent the possibility that they're gonna get an outright infarction. Trying to relieve their symptoms by vasodilators, trying to reduce the need for the heart to demand oxygen, try to treat the underlying coronary artery disease. So we're going to stabilize, we're going to relieve the symptoms, usually with nitrates or cardiac inhibitors, and then trying to find ways to reverse whatever obstruction is there. In terms of treating the underlying coronary artery disease, one of the most attractive ways from any number of for any number of reasons are the lipid lowering drugs. These are the drugs that are lowering the concentration of fatty acids, cholesterol, and other fat-like molecules from the blood plasma. And so there's a whole host of these things, again, because we can get at absorption or excretion by binding it up, making it more hydrophilic, making it more likely to be excreted. We can affect the metabolism, for instance, in the liver or other tissues. We can also affect the properties inside the vessels or the tissues as well. So I'll just give you the general families, and you should recognize these. Things like statins. These are drugs that are designed to inhibit an enzyme known as HMG-CoA reductase. Now, many folks have a form of this that is inhibited by cholesterol itself. So if you eat cholesterol and it comes in, it shuts down the endogenous cholesterol synthetic pathway. But people who have a history of what's called familial hypercholesteremia, that enzyme doesn't seem to shut down, and you keep making cholesterol even though you've got a boatload of it from your meal. So these statins are designed to shut down those enzymes so that you're not making any additional cholesterol that you might already have. Resins, these are going to bind the bile acids and make it less likely for things to be reabsorbed or absorbed in the first place. We have fibrates, which will help improve handling of fats in the blood plasma. They'll break down fats into fatty acids. We have niacin and nicotinic acid, and we also have other forms of absorption inhibitors, again with the idea of preventing the fat and cholesterol from coming in the first place. And I don't know if there's much more to say here. I thought I'd just go ahead and include this slide. You can see that there are all kinds of different types of lipoproteins and fatty acid molecule type structures that we find in the blood. Here's HDL and LDL down right here, high density lipoproteins and lows. And you get some very low ones. Again, the lows are sort of considered to be the enemy, and the highs are supposed to be our friends, and that's sort of true. The key is overall ratio of HDLs to LDLs as well as overall content, because even a boatload of HDLs can be problematic, because what's going to happen is they're going to be metabolized and or they may deposit even if they are considered quote unquote good. The key is to try to lower your overall triglycerides. Triglyceride content is elevated in folks that have metabolic syndrome who are on their way to diabetes, among other things. Same thing with smokers and so forth. It's one of those risk factors. When it comes to managing cholesterol, especially high cholesterol, the frontline drug and the one that's most commonly prescribed, it's truly what you would call a blockbuster family of drugs, are known as statins. Statins are a family of compounds that, first and foremost, will inhibit the synthesis of cholesterol. That is to say, precursors of cholesterol, fatty acids, will convert, starting with acetyl-CoA, and through a multi-step pathway, create cholesterol. And so this is the very, very first step. When you do that, what you're doing is you're lowering any additional synthesis of cholesterol above and beyond that which you take in with diet. Now, normally cholesterol will inhibit HMG-CoA reductase in a feedback pathway, but many isoforms of HMG-CoA reductase are somewhat resistant to cholesterol. That's the sort of genetic part of heart disease, is that the cholesterol that is in your bloodstream doesn't inhibit HMG-CoA reductase. So what they're doing with the statins is shutting down any additional cholesterol above and beyond that which you take in. So that's why a low-fat, low-cholesterol diet is just so very important, because it's not enough just to shut the statins down. You have to also modify your diet. The other side of HMG-CoA reductase is that you will stimulate the receptor. It will affect the receptor of cholesterol uptake. and that's called LDLR. So it's an LDL receptor. And what HMG-CoA reductase inhibitors do is they block that so that you're not bringing in more cholesterol. It helps, so it's helping prevent the synthesis of cholesterol, and it's helping prevent the uptake of cholesterol. So as I mentioned, statins will block cholesterol and they'll block the expression or synthesis of LDL receptor, preventing the uptake of cholesterol. So those are good things. Certainly will help reduce blood cholesterol. But the statins are well known for having adverse effects. It's a widely prescribed drug, and so we've seen many, many millions and millions of patients now taking this, and so we've seen a number of side effects that are reported. And so let's look at some of these. The two big ones are muscle pain and damage. Because cholesterol is so important in the fluidity of muscle membranes, and what you're doing is you're blocking endogenous creation of cholesterol. That may mean that a cell isn't getting as much cholesterol as it might need in order for a nice fluid membrane. So what you'll see is muscle pain. They might feel soreness, or they might have exercise intolerance. Rarely what you'll see is a breakdown of the muscle called rhabdomyolysis. Severe muscle pain, liver damage, and so forth. What's happening is the muscle is literally breaking down, and that inflammation is leading to other issues in other tissues. Liver damage is also one of the big ones. The liver handles a lot of the cholesterol, so if you're shutting down a key enzyme, it may be leading to buildup of inappropriate metabolites that are then stressing the hepatocytes out. So the big four: muscle pain, liver abnormalities. It is known that statins will interact with other drugs, so you have to be kind of careful with that. And of course, some other things that we see here: sexual dysfunction, neurologic, flushing, etc. But the big ones are muscle pain. That's the really big one. And then those liver abnormalities, where you begin to see sort of liver insufficiency. Let's just take a little aside here for just a moment and talk about an issue that is quite common in healthcare paradigms. And that is, if you have someone who has some sort of chronic illness, there's probably somebody out there who is willing, able, and aggressive, shall we say, in trying to hijack someone's wish for well-being. Let's put it that way. That's being nice. And what they will do is they will say, hey, you shouldn't trust the science. You shouldn't trust the scientists and the doctors. They have an agenda. You shouldn't trust the big pharmaceuticals. And a perfect example of this is right here. Statins kill, but cholesterol does not. Well, I beg to differ on that one, because we see over 1 million deaths every year from heart disease, and it's not because they're taking statins. So people will try to take advantage of a psychological weakness. They will use a person's fear, a person's natural skepticism. We mask incompetence in the veil of skepticism. That's what they call the Dunning-Kruger effect, by the way. In any case, the truth is that these statins really do their work. They really do help. It's just that they do have side effects, and what we have to do is our best to manage them and to continue to report, because more data is stronger. So that's why it's so important for you to be vigilant, to be informed, and to report new data. That's some of the most important things you can do. The last slide just deals with a few other cholesterol lowering drugs. Many of these are on the horizon or aren't quite as efficacious, or if someone has a severe reaction to statins, these are the ones that will be turned to. There are drugs that will basically chelate or bind bile acids. Bile acids are the way we emulsify fats. So by binding the bile acids, what you're doing is inactivating the ability to absorb. And so, what happens is when the liver secretes bile salts and bile acids, then most of those are actually reabsorbed. And so, by binding them up, you're preventing the mechanism of bringing fats in. So you're going to reduce cholesterol, you're going to increase the clearance of LDLs, certainly fewer side effects. So these things are getting attractive as they become more effective. The problem, though, is that when you start messing with the chemistry of the digestive tract, there's always a risk that you're going to have disturbances which lead to unpleasant side effects like loose stools, diarrhea, maybe occasional gas and pain. If you're locking up nutrients into the digestive tract, you're giving more food to the fauna that live there, and that is often what's causing the disturbance. Fibrates, what they're doing is they're manipulating what is being expressed by the liver. What we see is this conversion of LDLs to other types of particles. If LDLs are the worst, by changing the size of the particles, what you're doing is you're making it less likely for those fats to deposit in the arteries. So here's LDL right here. Here's really the good one, HDL. What we're talking about are some of these other ones. And there's a mixed bag on these. Some of these are okay, and some of them, there's still some open research there. Niacin and nicotinic acid, what we're doing here is the metabolism of free fatty acids. That is mobilizing fats from fat tissue. It alters that rate. It's slowing it down, so you can't mobilize fats to the bloodstream as quickly. And so the cells in the body, if they don't have glucose, will probably rely more on proteins and protein type sources. So it's going to reduce the LDLs. It'll certainly reduce molecules that might serve as inflammatory molecules, the fatty acids that lead, arachidonic acid, and some of these others that are converted into thromboxanes and other types of pro-inflammatory signals. Lastly, cholesterol absorption blockers. What we've got going on here, these are specific transport blockers. So they're targeting, they're sort of like bile acid binding drugs, only they're much more specific. They're going after the lacteals. At this time, we haven't investigated them enough to see how the side effect profile is in a truly large population, but it's coming because these drugs have now been on the market for a few years, and data is coming in, and so far it's looking pretty good. So that wraps it up for Chapter 7 on atherosclerosis and thrombosis and the implications of therapy. Again, we departed a little bit from the strict wording of the chapter. Just follow along on those topics that I covered. Go to the book, find those paragraphs where there's some discussion about what I'm talking about, like maybe basic mechanism of drugs, basic clotting mechanism, strategies for how we're dealing with these problems, and so forth. It's a little more holistic than the pure pharmacology that the book is treating, but it's also not nearly as technical. I hope you found this lecture useful, and I will talk with you soon. Thank you.